and in ethnic Chinese. This was an early study, but they did laparoscopic surgery. Their 38 kilogram weight loss, 95% cure of metabolic syndrome, and a minor complication rate. And in Australia, and just this line, if you're obese, your direct healthcare costs per year were $2,800, pensions, etc., that amount. If you lost weight, and this is from one of our major studies, your costs came down. We still haven't convinced the GPs to get people off pensions and back to work, but we're working on that. So we now have this algorithm, so depending on your BMI, you go down, and the complications, you go down one of those lines, and where, what the target is. So what are the outcomes? Well, 10% weight loss, we know for years, works. Reduces mortality, reduces blood pressure, reduces lipids, and reduces diabetes. The Swedish obese study showed improvements in mortality and cardiovascular events. I want to show this one, which is sibutramine, and some people on sibutramine and they were older than 55, had diabetes and cardiovascular disease, kept weight off for years, but for every kilogram of weight loss, and it didn't matter when it happened or whether people put weight back on, that they were in a program, for every kilogram there was a 6% reduction in the outcome events. So if you lost 3 kilos, there was a 20% reduction in the outcome events of this study. And it didn't matter whether you put weight back on. In GP land in England, they weighed people and said, oh, maybe you'd like to come onto our counterweight program, you need to lose a bit of weight. And over 2 years, the average weight loss was 2 kilos, 2.5 kilos. Do you think that's important? Well, drugs went down by 10% in men, 7% in women. Very important cost. And let me remind you that 4 kilograms weight loss prevents almost 60% of diabetes in those at risk. So what about it? They all regain. So this is what we expect. However, this is at one of the hospitals in Melbourne, and they use meal replacements and then pharmacotherapy. And this is Darjeeling, 23-year follow-up. So they did a 3-year intervention. One group lost weight, the other got nothing, and went back 20 years later, and there was still a reduction in mortality, in diabetes, and in cardiovascular disease. And this is the British, and I always need to say, the carotid intima media thickness, a surrogate cardiovascular measure. And this was the British 1946 birth cohort, so never overweight. This was their carotid intima media thickness. If they'd only been overweight for a little while, it was a bit worse. If they'd been overweight for a long while, it was a lot worse. But if they'd lost weight and gained weight at any time during that time, their carotid intima media thickness was better. And this is part of a phenomenon we call metabolic memory. So a really good weight loss attempt has great metabolic effects which stay. So the Darjeeling study and this show that. So weight loss is achievable for many, can be maintained, reduces mortality, prevents cancer, getting there, couple more slides, and a serious weight loss attempt has benefits years later. So what is needed? Trained workforce, clinical pathways, follow-up and re-intervention. And this is our health pathway, so our GPs or anyone can go onto this and it says what you need to do and where you can refer them. So, everyone knows, and we keep this updated. And so it's effective. There are short and long-term outcomes. We need to do prevention. It needs to be in primary care. We need management pathways and combined chronic care. So, obesity, lots of it. Needs to be recognised. We need prevention programs and policy, a stratified treatment approach, follow-up and retreatment, and this is effective. Thank you.